Okay, I'll try to remember to stay near the computer so that we have good audio. So the presentation tonight that we're doing is focusing on how to help people who are very weak. Their arm and their hand are very weak, and then in March next year we'll look at interventions for people who get to having quite advanced hand function but still have difficulty with using their knife and fork, writing and so forth, so more advanced training strategies. So the focus is very much here on impairment-based training, because we're looking at people here who maybe can't lift their arm off their lap, can't open their hand. So that's the focus of the session today. No, this is not going to advance at all. No. Switched off now, so let me try it on. Just hold on. Does it work with that? Not moving. Okay. Right. So I'm going to spend a little bit of time just going through 2 or 3 slides on analysis and a couple of videos, because it's important that you know how to identify when somebody's weak in particular muscles. Some of you might be very good at doing that, but we're making an assumption that you could probably do with a bit of a refresher. And for the benefit of stroke survivors and their families who are in the audience or who are listening to the webinar, some of the videos might be helpful for you in identifying where it is that you're particularly having problems with your arm or your hand. I'll just alert you to the most recent evidence in terms of systematic reviews around the focus of the area. And then the majority of the slides and the videos are of people who are trying to elicit a contraction in a muscle in their shoulder or their hand, or who already can perhaps lift their arm up onto the table but can't sustain it for very long. So we're looking at strengthening there. And then some slides that show you ways to improve the coordination of muscles working together, such as being able to reach forwards and open your hand at the same time, which for a lot of people is quite difficult and quite complex. And then towards the end, just looking at how to link some of the exercises together. So often people have exercises for their shoulder and their hand, and we have all these bits and pieces of exercises. And you need to keep reminding yourself and the person where they're going in terms of the activities that they're trying to get better at. So the take-home messages, I'll come back to them at the end, are that you need to analyse carefully, because if your analysis is not particularly good, then your training will not match the problems that the person needs to focus on. As a therapist, you need to know and to look for and to train the essential muscles for transporting the arm forwards and for opening the hand or pre-shaping the hand, what we call essential components. So always focusing on what's essential for the person to be able to reach and open their hand. And really emphasizing for you and for the stroke survivors that the hand is what drives the shoulder. It's the reason why we move our arm around, is to do things with our hand. So always have something in the hand, or be reaching for something with the hand. Not just, can you lift your arm in the air? Can you show me how you do this? Always something in the hand, taped to the hand, or reaching for something. In therapy, when you're, for example, working with somebody in the home or in the centre, keep your hands off. All the photographs, almost exclusively, you'll see in the videos, there's no therapy hands on. And that's because if people are going to improve their function at home, or in the hospital, for those of you who work in the hospital, they need to be able to practice on their own for many, many hours. And we know that the amount of practice that people do correlates with the improvement in recovery. So you can't be hanging off their arm for hours in a day. Typically, people are practicing mostly on their own. You're not with people very much in the day. So you're trying to set up the practice environment as much as possible in the hospital and in the home setting, so that people can do things on their own, using whatever setup they can at home. And often people with stroke and their families will come up with really inventive ways of doing the exercises that you've provided or suggested, and they're often better solutions than we can come up with. Practice doesn't have to be perfect, so it's much better that people are practicing something with their arm and their hand than nothing. So don't get too precious about how they're practicing or the quality of somebody's movement. You need to negotiate and help people to practice in the same way that if you exercise, you don't always find it easy to exercise, and keep going and doing your exercise regularly. You need buddies, you need people to help you and to encourage and motivate you. And it's even more important for people with stroke who are going to be practicing for 5 or 10 years to improve their recovery. If you do allocate practice, make sure you look at it. Make sure you talk about it when the person comes back, if they've spent time recording and doing their practice. And expect people will improve between every session and in every session that you're with them. And if they don't, be worried about it. Okay, that's what our job is to help coach and improve people's help people to improve their recovery, whether it's their walking or their arm. And if somebody's not changing from session to session to some degree, then you should be worried. You should be thinking about it between then and the next session. So that's the focus. And we'll start by looking at analysis. So if we think about what Janet Carr and Roberta Shepherd many years ago called essential components, that's the elements of an activity upon which the activity depends, whether it's reaching for a cup or being able to use a knife and fork. So it's common features across all of us, which is why it's referred to as essential components. And the term kinematic features means what we see when we watch somebody in a photograph or we watch them live or in a video. It's what we see their arm doing or their hand, how their hand opens. We can also make assumptions about what will happen when there are forces acting on the arm, such as gravity, which makes it harder for somebody to lift their arm up onto the table. And we can then set up the environment to make it easier for somebody. For example, if you ask somebody to reach for a glass, like the glass in front of me here, it's quite far away from me, it's quite high, it's going to be harder than if I have a cup that's directly in front of me and I don't have to lift my arm nearly as far or as high. So we can set up the environment and place objects that are close enough and near enough and low enough for somebody to be able to manage when we're starting with analysis and training. So just so we're all on the same page, if we think about reaching for that glass of red wine in the photograph there, that's what we call, what we're seeing at the upper arm between the elbow and the shoulders is what we often refer to as the transport phase. So we're transporting our hand forwards to the object. And we're looking at the humerus, or the bone that runs between the shoulder and the elbow. We also can look at what happens with your hand, so that what's called pre-shaping, the shape that your fingers and your thumb make, and the way that your wrist takes your hand back in order to be ready to accept and to grasp the object. So our brain anticipates the shape and the size and the weight of the object that we're about to pick up. And we position our fingers and our thumb accordingly. So we would expect in many of the tasks that you would be watching, and many tasks that people with stroke want to be able to achieve, that your fingers and your thumbs would be opposite. So in this photograph here, the thumb's directly opposite in the middle and the index finger. So you learn to look for that. If somebody's thumb's way up here, that's not what you would normally expect to see. The thumb's normally abducted and around for a glass like that. So if somebody's extending their thumb, it might suggest there's a problem with somebody's thumb abduction, being able to get their thumb around. When somebody actually makes contact with the object, whether it's a glass of red wine or whether it's a knife or a fork, I'm referring to that as the grasp phase. And often people with stroke have difficulty modulating the amount of force that they place on the object. They press too hard, they use too many muscles, not necessarily spasticity, just using too many muscles because they don't have good dexterity. And then in-hand manipulation is sometimes what happens at the same time as grasp. So when that glass is being picked up, you have to make some adjustments to your fingers underneath the glass. So that's in-hand manipulation. Or if you're picking up a knife or a fork or a pen, as soon as you grasp the object, you start to maneuver it in your hand to get it in position ready to use it for writing or to cut or to pick up a piece of food. So these two phases, grasp and in-hand manipulation, often happen at the same time, not one after the other. So just looking at the actual task of reaching for the glass of red wine here, it's on a table in front, and it's actually quite high for somebody who has difficulty using their shoulder muscles at the front. So what would we normally expect to see in terms of the transport phase? We'd normally expect to see what's known as shoulder forward flexion. So in particular, I'm looking here at, see if I can get this to show. I'm looking here at the humerus here, and the point of your elbow moving forwards from the side of the body. And it's a small amount of movement, but that's required for getting your arm forwards to the object. Also at the bottom photograph here, you can see there's some external rotation of this bone in your arm as it turns to place your hand where it needs to go. So in this case, reaching out to the side to place your fingers on the other side of the glass. You also need some protraction, so that means that your shoulder girdle starts to move forwards, particularly when an object is quite far away. So in addition to getting your arm up over the edge of the table, you need to be able to lift your arm against gravity, and your shoulder muscles allow you to flex forwards and to move into that external rotation. If you don't have the ability to do that, then you'll find other ways to get your hand to the glass. Now thinking about the shape that you would normally expect to see when you're analysing and watching somebody, and it can be very helpful to take a little video on an iPad or an iPhone in the same position as I'm in there with that photograph from in front or from the side, and then to watch it repeatedly with the person who's had a stroke so that you and they can start to analyse their movement together. So if we look at the bottom two photographs here, we can see that there's wrist extension, so the wrist has come back and the thumb is moving in direct line of sight towards the glass. There's some change in the position of the forearm. There's also some what we call thumb abduction, so there's a big space between the fingers and the thumb, big enough to take the glass. And there's some rotation at the bottom of your thumb, at the base of your thumb here, to be able to get the pad of your thumb opposite your index and middle fingers. And that's what gives you the good control and the good contact when you grasp the glass. You also need some extension at your knuckle joints, your metacarpal joints. If you don't have any extension at your metacarpal joints, you can't make the space that's necessary for a glass as large as that. And even if you're picking up something small, such as your glasses or a pen, you still need to make some space for the object to fit into. So some extension, some opening at your knuckles, as well as your small joints of your fingers, are essential components, essential for grasp and for reaching. And finally, in that bottom left photograph, you can see there's some spreading of the fingers to accommodate the shape of the glass and make sure the fingers have good contact. So if somebody has problems with those essential movements, those essential components, or any one of them, then they might compensate. They might start to find other ways, what we call substitutions, for the ability to move their arm forwards or to place their hand where it needs to go. So if we ask somebody, for example, in our initial meeting, to reach for a cup in front of them, if the person has difficulty moving their thumb out or opening their knuckles, they'll try and achieve the goal that you set them. They'll try and get their hand around the cup because that's what you've asked them to do. And they might do it by finding other ways, moving their arm out to the side, and they might be successful. And if they keep on doing that again and again, it's successful. Why wouldn't you keep doing it if your arm doesn't work the way it used to? So our job as therapists is to try and find physical setups, environmental setups, so people can start to practice getting back those missing essential components, whether it's shoulder flexion or wrist extension or thumb abduction. No amount of hands-on therapy is going to change that. Their brain has to get the messages to the arm, to the hand. So at that point, you're starting to test hypotheses about where you think the problems are. And people with stroke will know if their problem's in their shoulder or their hand or both. Your job is to try and untangle some of where you think the best place to start is with training and ideas for exercises. So you watch a task. It might be reaching for a cup or a glass. If somebody can't open their hand, then get them to put something in their hand, a paper cup, a polystyrene cup, tape it or bandage it in with Coban if they can't hold on to it. And that way somebody can move the object around, and then you can start to see how well their shoulder's working. And we'll look much more towards the manipulation side of training next year. Sometimes people have got tightening or shortening or stiffness in some of the muscles, so around their shoulder perhaps, or their wrist or their thumb, and you physically can feel to see whether there's a limitation there. And you can also palpate. Many of you will have done that, to see whether there's any actual contraction happening in the muscles that you're trying to get the person to use. So moving on now, we've got many muscles in the shoulder, lots of big muscles that you can see here, and lots of small muscles in the hand. But if we look at what a representation of our brain and the allocation of parts of our brain or our cortex to the shoulder versus the hand, what you see here is that there's lots of space and lots of neurons dedicated to our hands and not much to the shoulders, because you don't explore your environment with your shoulders. You explore your environment with your hands. Hence the reason for just emphasizing you should always try and have somebody have something in their hand or be reaching for something and to do something with an object. So if we look at this man here, he's been asked to reach for glass and he's successfully picked it up. But I know, because I was mentioning before that somebody's thumb would normally be opposite their middle and index finger, I'm thinking that maybe the reason this man's lifting his arm out to the side is because, maybe it's because he's got problems with his shoulder, but maybe it's because he's got a problem with his thumb. When he reaches forwards, his thumb doesn't move around into that opposition in the way that it should. So I'm starting to think about what the possible causes were or are. And in fact, when we start to look at his thumb, that was part of the reason. When he reached forwards, he positioned his hand like this and was able to successfully pick up the glass, but his thumb ends up on the top of the glass. So in this case, one of the main problems that this man had was his making the space with his thumb, and that's what caused all the problems with his shoulder. His shoulder was pretty good. So we're going to watch this lady who has slightly different problems, reaching for and picking up a glass. And I'll get you to just think about for yourself where you think her main problems might be. Are they at the shoulder, at the hand, or is it both? So I can see there that she's internally rotating her shoulder, and she's actually twisting her trunk to get forward. So I'm thinking she's probably got difficulty with her shoulder flexion, getting her arm forwards to the table, even though it's quite low. And she might also have some trouble with her external rotation, as well as possibly some problems with her thumb. Because as she reaches forward, her hand turns into some pronation. But I'm going to put my money on her shoulder. So the next thing I asked this lady to do was to sit down and I wanted to have a look at her left and her right hand together. And I placed a texture on the side of the chair here and asked her to see if she could lift them forwards and keep her elbow in. So that's the texture here on the left. And what you can see, she's having difficulty placing the glass, her left hand glass, directly in front of her on the table. So she's able to lift it up that small height. So that makes me think it might be the external rotation that's the main problem. So the next thing that I've done with my analysis is to just ask her to externally rotate with nothing in her hand, but with the glass in her hand a little bit beyond the texture on the table. And you can see that she has difficulty getting her arm very far. She can't get beyond 90 degrees in front. So that's the focus of that lady's training in this particular session, trying to be able to do more of that so that when she reaches forwards for glass, she can take her arm forwards and her hand forwards. So when we talk about hypothesizing about where you might want to focus training or where the person's main problems or missing components are, that's what we're referring to, and thinking about which muscles will need to be targeted for training. So where would you start? In this case, I've mentioned where I would start with that particular lady in the first session and give her some training for one particular area of her arm in the first session. Possibly some work on her thumb as well, but only a couple of exercises in the first session, and then see how well she goes with her practice between the first and the second session. And if she's managing well and she's practicing well, then perhaps add something else in a progressive exercise. But I wouldn't send somebody away with 6 exercises in the first session. See how well they practice in the first session. This lady here doesn't have as much movement in her hand. You can see that she's trying to reach for that paper cup, and she's not making, she's not really got much of a space. She can't get her thumb out. She can't open her knuckles or her fingers. So with her, I would be getting her to put the cup in her hand. It would probably stay there if it's quite light, but if not, I could bandage it on or co-band it on. And then look at some training at a low height to see whether she could slide it forwards, reduce the friction on the table. Can she practice getting her shoulder to move in this direction as well? And think about some other strategies, which you'll see in some slides shortly, that might help her brain to get messages to her muscles. So we're trying to drive neuroplasticity here. What we see is a change in somebody's movement, but really what we're trying to do by keeping our hands off is change their brain, help them to change their brain. So any questions or comments from anybody up to that point?
For your assessment, because I don't know how to do the relevant assessment, we do a global assessment and specific assessment of every muscle, plasticity, range of motion,
okay.
And after do the video analysis. No?
Okay, that's a good question. So I'll just repeat any of the questions for the benefit of the webinar. So the question was, would you do a full detailed assessment of the person's arm and spasticity and then go on with this? No, this is the start. This is the first 5 minutes of seeing that lady. So starting with an activity with an object in her hand or reaching for an object. And trying to, in that first hour, have the person go away with at least one exercise set up for practice with some measurements and some goals, and gradually picking up more information about what the person wants or needs to do during the session and subsequent sessions. I wouldn't measure muscle length. I wouldn't measure sensation with any standardized tests. I wouldn't do the same with spasticity because I don't have many strategies for addressing that. But I do have some strategies that might help the person to get their muscles to contract. We don't have any magic bullets, but trying to help the person go away with some exercise that they can use at home, that can follow at home, and then gradually building up some more information about the person, in addition to what you receive from, say, the hospital or from the person themselves about what they want to be able to do with their arm. Do you want to add anything more?
Yeah, I think there's a lot of preoccupation with assessment. And I think if you think about it, somebody comes to you because they want to change their function. And what's written on our assessment sheets really doesn't matter to that person. The most important thing for that person to go away with or to find out about is that they can do something. That's by far the most important thing. Your assessment sheets you will fill out over a period of time. But if you can try and imagine, I work in an acute hospital, if you try and imagine what happens to somebody when they have a stroke at the beginning, they come to a hospital, all of their freedoms are taken away, they're given gowns and all the rest of it, and everybody finds out all the things that they can't do. Everybody is preoccupied with everything that that person can't do. They already know what they can't do. They know right away what they can't do. They want to know what they can do. So the most critical thing when you see somebody is to find out what they can do. Your assessment sheets don't matter. They matter in the long term in terms of having some potential for measurement, but don't measure stuff you're not going to do anything about. There is absolutely no point. You're going to measure something, you must do something about it. So that would be my summary, quickly.
Any other questions?
I was just going to add with when you were talking about videoing and watching the task first. Obviously, that's very goal-driven as well. So I know you've got your specific kind of functions of the arm, but would you, if someone's goal, say, for example, was to be able to take their hand to their mouth, that's obviously what you're going to look at and what you're going to base the rest of your assessment in that particular session on.
So are you asking about what activities you might use in your assessment depending on the person's goals?
What you've given here is an example of someone who wants to be able to reach for a cup.
Yeah. So the question.
Would you go and look at these specific other tasks?
Okay. So the question is, I think, sort of what activities you might focus on depending on the person's goals. If somebody's got more advanced hand function, like that lady in the video there, then you have a bit more choice in the activities you can actually analyse on that first session or second session. If somebody can't lift their arm up off their lap, it's much more restricted. They might have a goal to be able to knit or to use cutlery, but they can't even hold it, let alone reach for it. So, I mean, reaching for a cup and drinking from a cup is probably a good place to start. For the OTs in the audience, it's better than cones and quoits. So a cup is something that everybody will have to probably pick up and use. So if anything, change to a cup rather than a quoit or a cone. And, you know, you can use a glass one, or you can use a paper one, or a polystyrene one, or a plastic one. So that, I mean, that's probably, I usually have things like that available when I'm doing an assessment, because I know that that's something everybody will have to pick up and use. And very often when you ask somebody what they want to do with their arm, they'll say everything and anything. Yeah. Okay, we might keep moving, and you can stop us at various points, and we'll ask for questions, invite questions. So just a couple of slides about the research. If you're wanting to know where to look and where to read, Cochrane reviews are a good summary of the research on, in this case, interventions to improve arm and hand function after stroke. They're freely available for anybody in Australia, not in every country, but in Australia they are. And there is a consumer summary for people who haven't had a health professional background that summarises what this means. And sometimes they're easier for us to read as well. So this study by the UK group, Pollock, Alex Pollock and his colleagues, just highlights the interventions that up to that point were shown to have moderate quality evidence. So it includes constraint-induced movement therapy, which is obviously not suitable for people who are very weak because they can't use their hand typically. Mental practice, mirror therapy, interventions for sensory impairment, which we won't talk about specifically tonight, and interventions that provide high dose of repetitive practice. And then there's moderate quality evidence that single arm training is better than bilateral arm training. So the juries basically said that bilateral arm training, doing two hands together, is no better than single arm training, but it's not harmful. So we're going to look at tonight, mirror therapy, electrical stimulation, repetitive task practice in particular in the limited time we have. This is another systematic review. Again, it's freely available to anybody who wants to read it. You don't have to have access to journals and library databases, and comes up with very similar conclusions as well. So I'm going to hand over to Karl now, but the focus that you'll see of all the different photographs and the videos tonight are that these interventions, particularly strength training, mirror therapy, we can't show you mental practice so easily, so I'm going to skip over that, but happy to answer questions. Electrical stimulation and single arm training all allow us to do very specific training of muscles or tasks. In this case, it's really muscles. Allow you to set up and the person to practice intensively and get multiple repetitions. And hopefully you'll get some examples here and some ideas that you can use with people that you work with.
Okay, task specificity, intensity, high repetitions. How many of you here know how much practice your patients did today? If you don't know, that's a problem, because there's a direct correlation between practice and outcomes. Sporting people know it, violinists know it, People without brain damage know it. And if this is our core business, we need to know it too. So number one, if there's one thing you take away from this session, set up a practice sheet that you can write down your patient's repetitions on, and that you give them a counter that they can count their repetitions, and you make sure that you check next time how much practice they've done. This is core business for us. What we're now going to do is look at some ideas around training. Annie has mentioned this idea that we have some essential components that we need to consider when we're training. So protraction is one, external rotation is another, and forward flexion is another. And if any one of those is missing, the way you reach will be different. So you have to have it, and so you have to seek it. And if somebody is unable to do any one of these things, then we need to find ways for them to do it. So what we're going to go now is through a number of ideas that we can measure their practice and we can look at what's going on. But just a very quick review, the major protractors are serratus anterior, as you know, but there's other muscles that are involved in protraction as well, pectoralis minor, major, and so on, will contribute to your arm to move forwards, to give you a stable scapula on the chest wall so your arm can begin to forward flex or externally rotate. Now here's an example of a man who was at a course we ran, and you can see here we have a very expensive cardboard cylinder around his arm. It's much, much cheaper than an air splint. They work just as well. This man had no movement at all. He was given some practice to do overnight. He could protract his arm a very tiny bit. You can see that he still has some trunk flexion here and a little bit of hip flexion to try and help. This man came back the next day. He'd done 200 repetitions and he was actually able to begin to protract his shoulder much more reliably. It's a palpable scapular movement on his chest wall. What's happened here is he has a goal to touch the table, so he has a point on the table to touch. There's a wooden cylinder under the cardboard to minimise the friction, and off he goes. Not expensive. Anybody's house will have all of the gear that you need to set up to be able to do this. You might need a bit of micropore, you might need some straws, but that's about it. The houses will have what you need to train them. So that's one example. So the goal might be, can you touch the table with a straw? It may be the person can't protract nearly as much and they may need another goal here. So, as I said, there's a round plastic cylinder there for them to roll on and they touch the table. So there's an outcome for their effort. And this is really important, that you need to have a goal that somebody is going to see and you need to have some way of measuring their change in performance. If somebody is only protracting a centimetre, you have to work out something that gives them an outcome. The nice thing about the straw is if this person can protract, even if it's just a centimetre, that straw, because of its length, will move much greater than a centimetre. And that's a good thing. You can get really excited about that. Because what's this man trying to do? He's trying to change his brain. He's trying to get neurons to talk to one another so his arm will work again. And we have to find ways that he can get some accurate information about the fact that his efforts are worthwhile. And if your goals aren't there, then why would you persist? Because we don't. If you have no goals, we don't persist, so why should he? So it's really important. So that's that idea again, just to review. Now the table could be higher, there's a whole range of environmental things, but the reality for this man, here he is counting his practice here, is that he was really, really pleased. This is the first time that he'd seen his arm move. For him, this was really exciting. Okay, here's an example of somebody set up at home with their arm with some foam around their elbow. Same idea, reaching forwards to touch a milk bottle. In this case, it's on a pen here that is stuck to the bottom of it. So the milk bottle moves away and then comes back towards them as their arm moves forwards and back. So there's some outcome in terms of where the bottle starts and where it gets to when their hand touches it. The only limitation for setups like these is your own imagination, which is really exciting. Okay, now external rotation. It's difficult. To reach forwards if you can get you all just to reach straight forwards as if you're going to pick up a glass, bend your elbow, and now externally rotate. Just to reach straight forwards, you use approximately 90 to 100% of your external rotation. If you're going to reach across your body, what stops your arm from internally rotating? Your external rotators. So thinking about gravity, external rotation is essential to move your arm and place your arm wherever you want to put it. The external rotation is missing, you can't get your arm forwards to where you want it to go. So, really important. But the thing that's interesting about external rotation, they're quite small muscles, but they are essential for reaching. So here's another example of a woman who has set up with her home practice here. This line is set up for her belly button. She's trying to slide her arm across this line here, her hand's on a washer, and eventually she's trying to get out to that cup. Between her elbow and her body is held a cup between her elbows so that she doesn't abduct her arm. So there's cloth under the hand to reduce the friction, and there's a cylinder down here. So she went from here to here with her overnight practice. This was the first time she'd seen her arm move in 3 months without her husband helping her. She was ecstatic that, in fact, that she'd been able to do this on her own. Now you can say, okay, well that's not where she needs to get to. The reality for this woman, this is probably a 10-year project. And we have to find ways that she can practice if she wants to continue to practice. And ways that she can see, because if we hadn't measured that, and as you can see, it's really complex, if she hadn't seen that change, she wouldn't have known that her practice was worthwhile. Even though it's only a couple of centimetres, it's fantastic because she's done it. Okay, now you can put electrical stimulation on external rotators as well. Usually a longer electrode here and the other one sort of up a little bit closer up here. And here's an example of somebody with 2 electrodes. These are actually smaller electrodes. Sometimes it's hard to get, but in this particular person, we've got a really good contraction. You can see infraspinatus here. So that's just the electrical stim working on their external rotators. So you can use electrical stim as well to help in terms of eliciting that information, that contraction. In terms of evidence, there's this recent meta-analysis, functional electrical stimulation improves activity after stroke, a systematic review, which goes on to suggest that there's change in function and strength. So it's a worthwhile paper. This is 2015, so it's a worthwhile paper to check up on now because it will summarise the evidence to date. Forward flexion, quite often quite difficult to find as well, but anterior deltoid, clavicular head of pecs, biceps coracobrachialis, and so on, to be able to move your arm forwards. Here's an example of a woman who was involved in a randomised trial up in Townsville, and this was her practice setup. She's trying to reach forwards between these 2 railway lines here. She's got a straw on her arm to maintain her arm and her external rotation resting along this block here, and she's reaching forwards to try and to stay within those 2 lines. So it's combining external rotation with forward flexion. Here's an example of a setup that one of the stroke survivors' husbands designed for her. He read about the smart arm from Townsville, but they didn't have all the gear, so he designed this machine himself. So this is a trolley on little rotating wheels, and she's able to, with the fixture here of these wooden doweling, that she can actually reach forwards. There's marks on the inside of this trough that you can see how far forward she's able to reach with her arm. You can modify the height of this as to whether it's lower or higher. So a simple solution to something that he'd read about. And so they now call this the strong arm. And there's David and Joy. There's on the website we have. There's the design of how to make this and so on. So it's freely available if you want to get someone to make one.
Oh, sorry, just with the previous slide.
This one?
Yeah.
Mm-hmm.
So you've got the two posts so the elbow. Like, there's the potential there, somebody could be pushing quite strongly. Would you say it would be, I guess it depends on the client, but preferable for those to be something that gives feedback if they are pressing too much against it? Like
This you could talk. I mean, I think gets down to the thing of practice versus practicing with compensations. She could be internally rotating, and this device just completely hides the fact that she's doing that. You would need to return back to that, as Annie was saying, return back to that criterion of can you now reach forwards without internally rotating. So probably in this case, and certainly I know in this woman's example, she needs to practice external rotation and forward flexion. This is one way of her practicing, but if all she was doing was using kind of other muscles, then this probably wouldn't be a good strategy. The other way that you can compensate here is by using your triceps. You can get apparent forward flexion at the shoulder by using your triceps to drive your elbow forwards. So you have to make sure that you can actually palpate some anterior deltoid actually happening. Otherwise, if they're not, then what they're practicing doing is that, which isn't terribly helpful when you want to reach. Particularly if they're doing thousands of repetitions. In terms of strength, this is a very crude example, but we know that a litre of water weighs a kilo, so you can just adjust the height of the water in this. This guy was a truckie and you need to get his shoulders a bit stronger, so just adding more water as one example. Now going back to people that have very little muscle activity once again, this is that same man we saw trying to protract. Here his arm is resting on what it happens to be in this case a mirror box catheter, and he's got two cans underneath and he's trying to reach forwards to touch this. There's books here under his elbow to raise his arm up to sort of more to 90 degrees flexion. Slide sheet to reduce the friction of his forearm. Cans underneath, straw taped underneath here so that this will tip when he touches it. You little beauty. This man didn't think that his arm would ever work again. And you can see that this is not perfect. You can see that he's doing other things, but is his elbow flexing and extending? It is. He's having a hard time there, but there's bits and pieces happening. Now the question is, do you leave him to practice like this? Yes. Because he's approximating what he needs to do. I think this idea about giving people stuff that's perfect when they're practicing is absolutely completely different from what we do. You don't go to a guitar player or a guitar lesson and he gives you the guitar and you can't play the piece perfectly. So you take the guitar away and you can't practice it for the rest of the week and you get the guitar back next week with the expectation you can play it perfectly. It's just silly. People need to have the opportunity to practice, to make mistakes and to learn from those mistakes. But what we need to do is to set up the practice in such a way that he can see that it's happening and that it approximates what he needs to do. It's not going to be perfect because he's had brain damage, and that's really important to acknowledge that. Okay, here's an example of EMG triggered electrical stimulation where in this case there's 3 electrodes, there's various types of machines. When there's a signal from the muscle that comes back to the machine, that reaches its threshold level, then you get this really nice triceps contraction. So ES can be used, you can use it on flexion and extension as well for somebody to be able to begin to use their muscles. Now, Annie was mentioning this idea around essential components for reaching. If you all make your hands in the shape that you need for a cup or a glass to reach for it, you're all making the same shape because you all know the shape of the cup. But you're all in sort of mid-position forearm, your wrists are all extended, your thumbs are adducted and your MCP joints are extended. And your IP joints are slightly flexed because the cup's slightly flexed. If any one of those things is missing, you can't reach like that. So that example of the man reaching for the glass with his shoulder in abduction, his thumb wasn't extended, neither was it abducted, it was halfway between. How do you pick something up when your thumb is halfway between extension and abduction? That's where the space is. The space is now here. So you put the space, you put your hand where the space is. So thumb, and one of the critical things I think when you're looking at somebody's arm function when they can begin to reach is always look for those three elements: extension, thumb abduction and MCP extension. If any one of them is missing, the way they reach for that cup or glass or whatever it is will be different. It will change the way their shoulders reach for that object because they can't make the shape they need. Okay, eliciting wrist extension. So ES is one way that has been, there's evidence around improving strength for these muscles. Whether it changes people functionally is the jury's still out. But in this case, there's a cup taped into their hand, there's a straw at the back of the hand for the person to try and get their hand back to. Electrodes are here and here. They're quite a long way away apart in this case, but this man is trying to keep his hand at the back of against the straw when the electrical stimulation stops. So trying to use his wrist extensors eccentrically. Here's an example of a woman who actually had very good shoulder control. Her shoulder control was fantastic, but she was unable to abduct her thumb and extend her wrist. So in this case, there are electrodes on the wrist extensors and the thumb abductors. So she can now begin to get some sort of shape that approximates what she needs to do without abducting, which is what she did previously, abduct, internally rotate. So it gives her a chance for her brain to start to think about the shape it needs to make as she's beginning to reach. Is there evidence that this is a good strategy? No. Seems like a sensible idea. But one thing I would say is beware of sensible ideas because they're not always good. But in this case, this lady was pleased that she's actually able to get some sort of shape to begin to reach. But obviously, as part of your training would be to seek thumb abduction, to seek wrist extension, and to seek MCP extension every time you see her. Because why? Because they're essential. Now, I'm just going to go back here a little bit. We need a bit of noise. Okay, so here's an example of any training using Skype as a means of training somebody.
This one?
Just keep your forearms still, just your wrist. Keep your forearms still.
Just your wrist, just your head.
Just your wrist.
And then try with your head.
Yeah, that's it.
Yeah.
So that's practicing your wrist extension. And you'd be doing that with a cup in your right hand, trying to get some movement in your wrist.
Backwards and forwards. This one?
Just keep your forearms still, just your wrist. Keep your forearms still.
Just your wrist, just your head.
Just your wrist.
And then.
So there's an example of using Mirrorbox via Skype. So the person's getting some feedback around their training and they're using their non-affected hand while their affected hand is within the Mirrorbox. So actually using, training by distance, if you like, which is now possible. It's fantastic. Okay, who's eligible? Basically severe or upper limb paralysis or weakness, acute, chronic, inpatient, home. Good Cochrane review, 2012. But you need to be involved in this systematically, 2 to 6 weeks, 10 to 60-minute sessions, 5 to 7 days a week. So it's actually a specific training strategy and you need to have perhaps using those essential components as elements of that training that the person is targeting. Forearm supination, just some ideas here. Person's ironing board, a ruler in their hand. The hand moves a little bit, the ruler moves a lot. Big bang for your buck, so you can start to see some large changes. This lady had a significant neglect, so taping the cup into her hand wasn't a good idea because she ignored what her hand was doing, but leaving her barely holding onto it meant that she had to concentrate on what she was doing. Thumb abduction, difficult muscle here to find, but here we're looking lumbricals, whole range of very beautiful muscles within the hand that are all essential. But you can start to get ES. So here's a goal with a person's thumb trying to reach between those two marks. electrical stimulation. So one of the electrodes on the base of the thumb here and the other one at the back of the wrist. Here's somebody already holding a large size object, and you can see here the conjunct rotation at the MCP joint. So you can sort of, once again, your imagination is the only limitation. So you can actually have the person's hand already around a large object and their thumb abductors get a chance to contract in that inner range, which they don't get a chance to otherwise. It's not a bad place to start. Here, just using the person's hand and actually sliding their thumb across their hand. Sometimes if the hand is a bit sticky, you can put a couple of pieces of paper to reduce the friction with a line on the bottom piece of paper. So when the person slides the top piece of paper across, it hides the line beneath. All sorts of ways that you can do it. This is from the physiotherapy exercise website. Just a paddle pop stick across the top of a cup, sliding a thumb to marks across the top of the paddle pop stick. Here's that example I was telling you before. This man is trying to slide the top sheet of paper across to hide the line on the other side. MCP extension, once again, a very expensive strategy here. Just a line at the MCP joint. This man is trying to get his MCP joint, and you can see that it's starting to extend a little bit. Once again, a reason to get excited. Okay, here's an example of somebody using mirror box. A bit hard to see in the screen there, but this is the non-affected hand, and this is the affected hand, and this is a video that her husband took of her practicing with using mirror box. So you can see that there's some training going on there. In terms of driving practice, here's an example with a splint. This woman was trying to get better at using from a constraint-induced movement therapy fortnight that this woman was involved in, and she was doing somewhere in the region of 250 repetitions an hour and really trying to get to drive her little finger to begin to extend.
A lady who wanted to be able to use her keyboard and use her little finger to hold the keyboard, one of the shift keys down. So that's why she's practicing MCP, flexion extension at her knuckles. And she's getting better at not using her wrist. You can see that she's using her wrist initially. Now she's getting better at keeping her wrist relaxed and just trying to get her little finger to work. Initially, I just take the two fingers together, her ring and her little finger, and then unstrap them and just have the single finger working on its own. And then the next video is where she's got a goal to reach up to, so she's extending a little bit higher, and again aiming for as many repetitions in 30 seconds as she can. Question down here.
Sorry.
Question.
How do you deal with the issue though of muscle fatigue of people figuring out after 6 reps?
Keep going. Seriously, people need to learn how to persist. Their brains need to learn how to persist. So you give them a little bit of a breather and then you go there again. And you go there again. Because that's what they need to do. But it's hard, it's tough. I mean, I don't know what it's like to have to try to get neurons to connect again and to make them work again. But if we don't get people to persist, then it's unlikely that they will do it on their own. So then we start to bring these individual goals together to relate to an overall task. So Annie was saying before that you actually get somebody to reach for something at the beginning. Then each one of these things that we've been looking at, can they externally rotate, can they forward flex, can they extend their wrist, can they abduct their thumb, that relates to actually reaching for something. And it's really important always to return to that so you keep your head and the person that's actually putting all this work in as to where they're going and why they're doing it. We wouldn't keep going if we didn't know either. So there's those examples we've talked about. And here's an example of a man that's actually practicing a more complex task. He's holding a cup. And what he's trying to do, and you can see he has significant difficulties maintaining the wrist extension while he tries to let go of the cup. And until he learns how to be able to maintain his wrist extension and abduct his thumb, it will always be profoundly difficult for him to grasp and release a cup. So be able to maintain wrist extension while you abduct your thumb, this pre-shaping shape that we all made so easily and effortlessly, you need to be able to maintain your wrist extension, which you can get apparent thumb abduction by flexing your wrist. But it's not helpful to reach for something because your fingers get in the way. So it's really important. So this is one of the things that this man is trying to do, is to keep his wrist against the straw, maintain the extension, while he tries to let go with his thumb, and it's profoundly difficult. We're kind of running out of time here, but...
okay, there's only 2 slides to go. Any questions at that point? Yeah.
I frequently see people with a lot of flexion, but their extension may not have been at all.
Yeah.
So in the example that you had, elbow flexion extension of a lot of tins, what do you suggest to your patients who are just starting to get those beautiful little flickers of flexion and yet cannot do the extension to match? Do you let them move their head out?
Yeah, absolutely. Yeah.
Would you help them yourself? What would you suggest?
If you're setting up for their practice at home, I'd get them to do it themselves. But possibly also use ES on their extensors. So ES for 10 seconds and then they flex, they do what flexion they can, and then so you could actually set it up that way as well. So there's other ways you can kind of play with those things. But it's a good question. I think sometimes if somebody can move in one direction, you're not going to say, well, no, don't do that, because in fact it's really exciting. But equally you would have a conversation, and it's also important to be able to straighten your arm as well, and so you need to really work. So maybe that's where the mirror box would come in or something, that they're actually really working for extension while they can actually get their flexion without the mirror box.
Would it be wrong to suggest that they can apply mental practice of where the muscle is, how to get their arm, as they do, as...
There's nothing wrong in this. I think it's really exploring. It's really exploring ideas for people to give them the opportunities to begin to practice.
Yeah, I mean, the idea of using mental practice while they're at rest in bed or sitting at the table, and then do some actual practice as well. So thinking about their arm extending and then actually trying to do it. And the mental practice, when we teach that in a workshop, it's usually one practice of doing it then, or attempt at doing it, and then one mental practice and alternating between it. So I'm thinking about my arm straightening out to touch that target, then I physically try, even if I'm not getting anything happening at this point. So I might keep on going with a couple more slides, and we're nearly at the end there. I mentioned at the beginning that you want to try and minimise manual guidance for all those reasons that have hopefully been emphasised through the session, that if somebody's going to practice on their own, you have to help to set up the practice so that you're not going to be in the picture as part of their home practice. So it might be useful to give people the idea of movement for safety if they're not looking after their arm well, and to help people focus on particular aspects of the exercise or the movement. But the problems are that it will often disguise the compensations, which you want the person to recognise when they're working on their own. You can't possibly replicate the movement of the arm, it's so complex. It requires a lot less of their involvement, and their brain needs to be engaged if they're going to get their muscles to switch on and coordinate their muscles. And it's probably an easy option for you. Bottom line, you need to use your brain a lot more to think about strategies and ways to set up practice. Putting your hands on is a much easier option. So if you're a hands-on person, think about that tomorrow or the next day when you're working with somebody. You probably do it without thinking about it.
Just, it's not, I guess not so much manual guidance from therapists, but what are your thoughts on, just that example before, how you had the cup and you had difficulty maintaining wrist extension to abduct your thumb to let go? What are your thoughts? I guess it's similar to that thing that the gentleman's, the wife, the lady's husband created. Yeah. In terms of, say, like a wrist cock-up splint that supports an extension.
Yeah, good idea.
Could you then perhaps practice that with the wrist supported in extension?
Yeah. So the question was, could you put a splint on that would hold the person's wrist or their thumb in the desired position and then practice with it? Yeah, great idea. And then take it off, so with and without. Yeah. Try and get the person's hand or thumb or wrist in the position it needs to be in. then take it off and see if they can maintain the position without that. It's a bit like using electrical stimulation. Yeah. But good question, good ideas. And there's no trials about the effect of that. It's just good ideas. And if you're going to see a benefit, you'll see it immediately. Yeah. So I think before you put your hands on, because think about why you're doing it, think about what you're going to learn, but more importantly, what's the person you're working with going to learn by your hands being on them. And just look at some of the ideas of ways that you can set the practice up alternatively for the person to practice alone or semi-supervised with their relative. And clearly there are some people who can't practice on their own and they do need somebody else to drive that along for them. But the manual guidance is probably something to think carefully about. 2 or 3 slides just about increasing intensity. For those of you who don't know some of these studies, there's a group in America that have been systematically looking at ways to increase repetitions. And the initial study that they did, Catherine Lang's group did, watched therapists and patients in a number of centres in the North American, Canada and the US, and found on average people were doing only 32 repetitions in an hour. That's not going to change anything. So what they did was then say to people who are inpatients and outpatients, the aim is 300 repetitions spread across 3 or 4 exercises in the hour, and that's the target for the day today, the session today. And so they had, first of all, they had 15 outpatients who did that, who were at least 6 months post-stroke. Were doing a range of activities in their sessions, and the average at the end of the period of this study was 332 reps, with a range between 285 and 358. And they got quite significant changes on this standardized measure, the Action Research Arm Test. Then they went on and replicated that with people who had much more recently had their stroke in hospital, with all the challenges that people have early after their stroke. And lo and behold, if you set a goal and a target, and you keep to that target and you measure and you give feedback, people can achieve that. So think about that. That's for 250, 300 reps in a session. Think about that as a target that you might want. Even if somebody only gets to 50 or 100, that's better than 30. And that's what's going to help to improve their performance, is practice and repetitions. Any questions, comments?
When patients just don't have the motivation, like you can explain it, you can tell them you can do it, set them up, and I mean obviously they're adjusting and you've got different personality types, and you can go and some who don't. I've just got a gentleman with a Korean background at the moment, and there's potential, but he's just culturally or cognitively just going, no, I'm not going to do anything.
Yeah. I might make a comment and then I'll see if Karl wants to make a comment, because he works with people in hospital, which is a different setting. So the question for the webinar was, how do you help people? And I've intentionally said, how do you help people who have problems with motivation and I'm not going to use the word compliance, participating in rehabilitation. Karl can perhaps talk about that, but I would say there are some people who are keen and are going to practice, and our job is to find things that are sensible and beneficial for them to practice because they're going to do it anyway. And there are other people where, you know, their focus on their rehabilitation is not a priority. Some people do have problems because of their stroke or their brain injury. That means that their ability to be motivated is different.
I think it is an interesting thing, and it is problematic, and we kind of make judgments about how come this guy can't practice. I think sometimes group settings are helpful, so people can see other people practicing. And so we have an upper limb group at work where people practice together, and so some people see other people practicing, and so that can sort of feed off one another. But it is interesting, those cultural things. People can actually learn to do things very well. I distinctly remember training a man to use chopsticks again. He was able to use it for all his meals and went home, and 3 months later was being fed by his family. I mean, people, you know, families and people make decisions, and so we can't judge people for that, but I think I learned a lot from training him how to use chopsticks. Obviously, it didn't stick enough for him in terms of the importance to him and what happened to him. So maybe we chose the wrong problem. Maybe we chose that if he'd been better able to cope with his stroke, might have been a better place to start for him to then.
I mean, I guess I'm struggling with going, well, if you're not going to participate, then we have to cease your program. You know,
Sure,
do
and if it's an outpatient situation, I think a colleague of mine that looked at the issues around people practicing in rehabilitation gyms, and her message from that after looking at the Fiona Mackey was looking at those things, and she set up, gave people practice to do, and if they hadn't done their practice for the week or whatever, when she was seeing them, there was a practice corner, and they have to complete their practice before she saw them. Because she said, this place is busy, and I can't have, if you're not practicing, I can't continue to see you. And so do your practice, and then, well, I'll have a look. And if that happened over a series of times, that you say, well, obviously this is not the right time for you, and perhaps it's better to maybe come back in 6 months when you're ready to do some practice.
Actually, we see a lot of clients like that. We've got a client who is not we're not focusing on upper limb. It's incredibly non-functional. It's not a priority for him, but he actually didn't achieve anything in his inpatient setting with severe depression. And actually 6 months later, he's now doing the stepping transfer work with discharge of the voice. I think timing is really important. I think he's now medicated and
It's just hard because this guy's life wants him to do it.
Yeah, you know.
But it's not her arm, it's his arm.
Yeah.
Exactly.
Really hard to step inside somebody's head. Measuring change. I mentioned earlier about the idea of assessing. So measure stuff you're going to do something about. So it's really important. So in some ways, reaching for a glass offers so many inbuilt measures. How far can the person reach without internally rotating and adducting? How high can they reach? There's a whole range of things you can build into that right from the start. So the tasks themselves can actually provide you with the measures that you need. It may be the time or the speed they take, it could be the accuracy of the performance, it could be the limb trajectory, for example, that whiteboard marker that Annie was using for that person to try and keep her elbow by her side when she's reaching forwards, size of the object, the distance they can move it. And for people that are having this really, particularly ataxic, percentage success is a really good thing to use. So you've got 2 out of 10, so give them a set number of repetitions to do, like have 10 goes at this, they get 2 right, so okay, this time see if you can get 3, see if you can get 4. So there's some measurable change in performance. And sometimes percentage success is a good place to start. So it may be that somebody's trying to get some abduction, and that example of the man trying to maintain his wrist extension, some abduction, it may be how many times out of 10 can you begin to abduct his thumb before his wrists flex? And maybe it's 1 out of 10 on day 1, and you try it with the wrist, the cock up splint and the abduction, and then you come back to that and say, how many times can you do it now without your wrist flexing? But they've got to be simple, they've got to be straightforward, they've got to be right then and there. So there's some standardised measures that do capture change in people who are very weak. The motor assessment scale and the box and block test is, if somebody has some grasp, that's one to use. But the major thing is actually these things about changing our practice. If you don't know how much practice people are doing, then that's a place to start. We need to intensify the practice that people are doing and not be preoccupied with assessment. If you've got a 5-page assessment sheet and then you have a look at your admissions and your discharges and you find that half of that sheet isn't filled out for their discharge, then maybe those measures don't need to be included. And if you're measuring a whole bunch of stuff that you don't do anything about, then maybe you don't need to measure those things. Yes, okay, so take-home messages. Analyse carefully, seek and train muscles. So the purpose of actually having some essential components is that you know what's essential and you're going to target those muscles. Hand drives the shoulder. We don't fling our arms around for nothing. Use manual guidance judiciously. Try to set up practice to minimise compensations, and that's quite often very difficult to do. Practice doesn't have to be perfect. Negotiate a practice rep, so that idea of a goal of 300 perhaps. And if you're going to allocate practice, review it. Because recently a man came to a course and he was a bit aphasic, and so he found it difficult to express what he's saying. This therapist gave me this stuff to do, and I did it, and they didn't ask me. And I said, I did 250, and she didn't ask to see it. And he was pissed off.
One more.
Is there? One more. Okay. Expect people to improve. Every time you see somebody, you should expect to see a change.
Okay, that's it. If you'd like to finish it recording. And then if there are any extra questions once we've finished that, because an hour is quite long to listen to a webinar.